Welcome, everybody. Welcome to Grand Rounds at the UCSF Osher Center for Integrative Health. My name is Shelley Adler, and I'm delighted to serve as the director of the Osher Center. I am hosting today from Seattle, Washington, where we are in the middle of the annual meeting for the Osher Collaborative, which is the network of 11 Osher centers around the world. So I am more remote than usual today. It is my supreme pleasure to introduce Dr. Mary Jo Kreitzer, our speaker for today. Mary Jo is a dear friend and colleague, and truly a pioneer in the field of integrative nursing and in interprofessionalism in integrative health. Dr. Kreitzer is founder and director of the Earl E. Bakken Center for Spirituality and Healing at the University of Minnesota, where she's also a professor in the School of Nursing. Dr. Kreitzer earned her doctoral degree in public health, focused on health services, research, policy, and administration, and in true interprofessional style, also holds master's and bachelor's degrees in nursing. In 2020, Dr. Kreitzer became a distinguished policy fellow in the National Academies of Practice and was inducted as a fellow of the Faculty of Nursing and Midwifery in the Royal College of Surgeons in Ireland. And she is also very well known for her wonderful work as a co-editor of a seminal text, Integrative Nursing. Dr. Kreitzer has been PI, co-PI of many clinical trials focusing on mindfulness meditation with people with chronic disease, including studies focusing on solid organ transplant, cardiovascular disease, chronic insomnia, diabetes, and also focusing on caregivers of people with Alzheimer's disease. Some of her recent studies include the use of social technology to enhance healing and well-being, and also the impact of mindfulness on brain-computer interface performance. I honestly, I could not be happier. And Mary Jo is also working with us. She's been a wonderful friend and consultant to the Osher Center informally, and we're looking at developing an integrative nursing training program, which hopefully we'll have more information on in the coming months. After Dr. Kreitzer's presentation, we'll have about 15 minutes for discussion. So what you can do is submit questions to me by way of the chat feature anytime throughout the presentation if you want to just ask a question and then not have to try to remember it. And you can also pose any questions directly to Dr. Kreitzer after the discussion. Lastly, I want to thank our Grand Rounds Planning Committee, Drs. Selena Chan and Anand Dhruva, who are actually here in Seattle with me, and also Dr. Patty Moran, as well as Jen Shea and Yvette Coulter. Thank you so much for joining us today, and please join me in welcoming our speaker. Thanks so much for being here, Mary Jo.
Well, thank you so much, Shelley, for that warm welcome and introduction. It truly is a pleasure for me to be with you all today. So you'll see in the topic of my presentation, Integrative Nursing, a way forward in turbulent and uncertain times. I do want to reflect for just a moment about these times that we are in. They are indeed turbulent and uncertain. And that's true in our personal lives. It's also true within healthcare, society as a whole, and our planet. I think there's never been a time more important for the work of the Osher Center in advancing whole person strategy in all aspects of their work. So I want to begin by reflecting a little bit on where we are within healthcare, because being turbulent and uncertain is not a new reality within our healthcare context. Honestly, if you look over the past decade, from a patient care perspective, there have been issues with access to care, clinical outcomes, the cost of care, and lack of coordination and continuity. There's many studies that show that when you look at the United States relative to the rest of the Western world, our care is more costly and we achieve outcomes that are near the bottom of those countries. The other issue that's pressing is the well-being of the healthcare workforce. And this too is not a new issue: stress, burnout, and early exit from the profession. Although the dual pandemics that we've encountered in the last few years, both with COVID-19 and with systemic racism, these pandemics have only exacerbated long-standing issues. The health inequities within the healthcare system have become even more apparent. And with systemic racism, the barriers to access and the impact that has on the well-being of the healthcare workforce is becoming more evident each day. So as I talk today about integrative nursing, I don't want to be presenting integrative nursing as a panacea that is going to solve all of these issues, but it is a strategy for addressing, as you'll see, both fundamental issues as well as system issues. So what I'm going to present today is a framework for practice. I'm going to talk about principles of integrative nursing and how these principles are applicable across clinical settings and patient populations. And I know there are some nurses on the call today, and there may be many of you that are not nurses. And so while this content is highly relevant to nursing, I think you'll find that the principles, as I talk about them and how they are applied, are also universal. I hope that you'll see that integrative nursing is a strategy to achieve institutional goals and priorities and to really impact outcomes, that it's not integrative nursing just for the sake of integrative nursing. And I think it also is an important strategy for restoring meaning, joy, and I would even use the word integrity to our clinical practice. So very quickly, I'll just identify the 6 principles of integrative nursing, and then I'll go a bit deeper. So the first principle is that people are whole systems, inseparable and influenced from their environments. So that's why it's so critical that we look at people from a whole person, body, mind, spirit perspective. That as humans, we have the innate capacity for healing and well-being. That integrative nursing is a person-centered and relationship-based approach. That nature has healing and restorative properties that contribute to health and well-being, and that integrative nursing is informed by evidence and uses a full range of conventional and integrative approaches, employing the least intensive intervention possible depending on the need and context. And I'll be sharing some examples with you. And finally, the 6th principle of integrative nursing is that it focuses on the health and well-being of caregivers as well as those they serve. So I want you to imagine yourself as a patient within UCSF, or maybe imagine someone you love being a patient, and think about what would be important to you from a patient experience perspective. I think if you or someone you love were to become a patient at UCSF, you'd want a nurse that would go beyond your diagnosis, your vital signs, your admission history to find out who you really are. You'd want a caregiver that knows you, your story, and what matters to you. You'd want a nurse who could help you tap into your innate capacity to heal. And you'd want to be in a space that enables you to connect with nature, be that through art, light, imagery, and a nursing staff that is attentive to noise and privacy. And you'd want to have a nurse who will make sure that your care is coordinated, someone you feel connected to and connect the dots. And if you were to experience pain, nausea, anxiety, or have difficulty sleeping, you'd be very well served to have a nurse that could offer you aromatherapy, mind, body, breath, relaxation approaches, imagery, acupressure, and if needed, put in an order for acupuncture and administer medications. And finally, you'd be well cared for if you had a nurse who was investing in his or her own well-being. We know that it's very difficult to give what you don't have. And so what I'm really describing is integrative nursing. Integrative nursing is not just what we do, it's who we are. It's a way of being, doing, and knowing that advances a whole health perspective to optimize well-being. Integrative nurses use evidence-informed strategies to support whole person, whole system, and planetary healing. And today, my focus is going to be more on whole person, a little bit on system, but it's a holistic frame of mind that really advances all of those outcomes. So I'm going to take each one of these principles and go just a little bit deeper. And as I do that, I invite you to think about if you were implementing this principle in your practice, what would it look like? Because that is, in fact, what we encourage people to do. So when we work, whether it's in community-based settings, in ambulatory clinics, or in hospital-based settings, we really work with clinicians, with nurses to say, if this principle was being implemented, what is it that the healthcare staff, that the nursing staff would be doing? So the first principle being human beings are whole systems inseparable from and influenced by their environments. That's why it's so important that we take a whole person perspective, attentive to body, mind, and spirit. And you'll notice that I talk a lot about well-being. And well-being is more than health. It encompasses health, but it also encompasses purpose, relationships, community, safety and security, and the whole broader area of the environment. This principle also encompasses the social determinants of health. And we know that everything that surrounds the patient and their family, economic stability, access to education, access to healthcare, the neighborhood, the built environment, that whole social and community context has a big impact on healthcare outcomes. So that's why, as we think of making our assessments, we have to assess much more than physical needs. We need to be looking at emotional, spiritual, and social needs. We need to really capture the patient's story, understand needs and strengths and preferences and what matters most. Be attentive to the immediate environment, the physical environment, paying attention to things such as noise, smell, temperature, and privacy. If any of you have been hospitalized, you know that these are big issues in an inpatient setting. And it's important to recognize that you, the nurse or the clinician, are part of that environment. So the attitudes, the actions, the body language that we bring to a clinical counter is really critical. And it's important that we be attentive to those social determinants of health. So encompass in our assessment and care, looking at housing, looking at issues of barriers that might manifest in racism, discrimination, and violence. We look at education, job opportunities, education. We look at issues such as food insecurity. Do people have access to nutritious foods, access to places to engage in physical activity? And we look at other environmental issues such as polluted air and water, language, and literary skills. So that's the first principle of integrative nursing. And when we go into an organization, we'll often work with an organization on what do nurses, what do clinicians do across the health system, across the clinical enterprise, and then take it down to the level of the clinic, the community setting, the patient care unit, knowing that a mother-baby unit is different than a post-anesthesia care unit, is different than an oncology unit. And so one of the things that I've really discovered that I enjoy is that peeling apart these principles and looking at how they're applicable across clinical settings and patient populations is truly a way for clinicians to own their practice and really think about how do they want to practice, what's really important to them. So the second principle of integrative nursing is that as humans, we do in fact have an innate capacity for healing, innate from within, healing to make whole. There is a self-healing, innate restorative capacity of the human body. And you know that healing can occur on a physical level. If there's a break in the integument of the skin, we don't have to tell our body to go into a system of repair. Automatically, our system, our system, our skin begins a process of healing. If people experience liver damage or kidney damage that's not too severe, there is a capacity for healing and restoration. We know that nerve cells don't regenerate in the same way, but even spinal cord injury patients for up to a year post an injury often can experience some restoration or healing. And of course, there are amazing breakthroughs happening in the whole area of the brain and neuroscience. We know that the brains of meditators are different from the brains of people who don't meditate. Through our thoughts, through practices like meditation, we can literally change the structure and function of the brain. There's evidence that there's with people who are long-term meditators, that there's activation in the left prefrontal cortex of the brain, which is the seat of positive emotions. There's also been a lot of research on the whole impact of positive emotions, and I particularly am drawn to the work of Dr. Barbara Fredrickson at the University of North Carolina. And she's written many books. This one is titled Positivity. And in her lab, they've demonstrated that when we are in a positive emotional state, our brain is flooded with dopamine and serotonin that enhances our immune system, diminishes the inflammatory response, and literally changes the scope and the boundaries of the brain. We can actually perceive and integrate more information. So what does this mean? How do you take this science and say, what are the implications for practice? And so these are just a few, suggestions. The importance of nurturing the growth of hope, trust, and belief, facilitating connections and relationships that lead to deeper meaning and wholeness, empowering people and their families by engaging and supporting strengths, encouraging mind-body practices. So those are the first two principles. The third principle is that integrative nursing is person-centered and relationship-based. And there's so much evidence that relationships are core to healing. And as nurses, we talk a lot about the importance of caring, empathy, and compassion. And I want to peel those just apart just a little bit. One of our leaders, and has a huge legacy in nursing, is Dr. Madeline Leiniger. And she wrote that caring is nursing and nursing is caring, that these two are synonymous. Dr. Jean Watson, who has a huge body of work on caring science, talks about that caring is the essence of nursing. And she talks a lot about caring moments. And in our practice, over the years of practice, we may, in fact, have these caring moments with patients that, as Jean describes, are the very reason that we are here on this earth at this time. So caring is really an essence of nursing. And Dr. Watson and I have published several papers and book chapters together. And Jean Watson describes the universals of caring as being parallel to the universals of healing that come from the integrative nursing principles. And together they form a more comprehensive caring and healing praxis model. So we know caring is important. We know that also that empathy is important. Empathy is the feeling and understanding another person's emotions. It's a precursor that motivates actions of compassion. Numerous studies over the last decade have reported the decline of empathy in medical students and residents over time. There have been fewer studies that have been done with other health professionals, including nursing, but I think we need to be asking ourselves, what happens to nursing students and what happens to nurses when they are in practice? Does their empathy increase or does their empathy erode? And then there's a really compelling work coming out on compassion. And if you haven't read this book by Stephen Trzeciak, I really encourage you to. Stephen is a physician that wrote this book titled Compassionomics, the revolutionary scientific evidence that caring makes a difference. And he defines compassion as the emotional response to another person's pain and suffering. It involves an authentic desire to help, and it involves taking action. So empathy is a feeling, compassion involves taking action. According to studies, nearly half of the Americans feel that the US healthcare system and healthcare providers are not compassionate. That is like a really significant data point. And in this book, what Dr. Trzeciak and Mazzarelli do is they review well over 1,000 studies and look at the fact that there's overwhelming evidence that the effect that compassion has on patient outcomes, so a set of studies on patient outcomes, patient safety, provider well-being, employee engagement, and organizational performance. So compassion has a huge impact. A few studies that are cited that I think are important. One study was a Johns Hopkins study where 74% of the interactions by healthcare professionals, verbal and nonverbal, in the ICU showed no compassion for patients and families, zero compassionate behaviors. A study at the University of Washington, 1/3 of end-of-life discussions with families in the ICU had no statements of compassion by healthcare providers. On the positive side, having a patient experience compassion does not always take a huge amount of time. This was another interesting Johns Hopkins RCT that was done where the intervention was compassion inserted into a standard oncology consultation where the outcome was anxiety. And in the interaction with patients, with women with breast cancer, it was the actual study, the physician inserted this one phrase: "I know that this is a tough experience to go through, and I want you to know that I'm here with you. We're here together, and we will go through this together, and I'll be with you each step of the way." Compassionate statements such as this from a healthcare provider can reduce anxiety in both meaningful as well as measurable ways. So, what are the kinds of things that we do to demonstrate being person-centered, relationship-based, and being demonstrating caring and compassion? Simple, but yet not trivial things: greeting patients and family members by name, knowing a person's life story and their context, leaning in, making eye contact, using facial expressions such as smiling and nodding, promoting bedside handoff. There's literature that shows that the impact of compassion is cumulative. And so really developing a culture where this is important can make a big difference. And developing staffing and scheduling patterns that lead to continuity of nurse or clinician patient relationships and care. It's very difficult to be person-centered and relationship-based when you never see the same nurse twice. And so that's why developing and looking at system issues like staffing and scheduling is so important. For nurses, setting an intention to be a healing presence each shift and coming back to that before interacting with patients, practicing deep listening, asking open-ended questions, cultivating the capacity to be present. So at the Osher Center, you do so much with mindfulness, and mindfulness is such a good way for us to be able to center, to ground, to set an intention, to use things even like hand washing and thresholds as we cross the threshold of a patient's room, as setting an intention as we enter a patient room, as we exit, sort of letting go of the energy of that encounter. And when we cultivate practices such as mindfulness, it enables us to be in the present moment and to do these practices. So the fourth principle of integrative nursing is that nature has healing and restorative properties that contribute to health and well-being. And this is an area that I get so excited about. At the Bakken Center, we began introducing nature-based interventions and courses on nature-based healing a decade ago, and it was considered such an outlier. And now there's not just hundreds, but there are thousands of studies that shows that encounters with nature and being in nature can reduce stress, improve sleep, decrease anxiety and depression, lead to greater happiness and life satisfaction, reduce aggression. There are in the whole world of evidence-based design, many studies that have demonstrated a link between the environment and health outcomes. In fact, there's an Institute for Architecture and Neuroscience that shows that there is a science emerging that underlies healing environments. And so in many of our clinical facilities now, there is attention to bringing in healing gardens and healing spaces. And I know that at the Osher Center, you have a beautiful Zen garden that I have been in with Dr. Adler, and it's a beautiful place for respite and healing. So I won't go into detail, but so much work being done with creating spaces that are very attentive to creating zones for patients, for families, as well as for the clinical care. So from a nursing care perspective, what are the things that we can do? Provide access to natural light. And sometimes the simple gesture of opening blinds or shades or curtains, displaying pictures of nature in patient rooms and public spaces, integrating art and guided imagery that draws upon nature into care, facilitating green exercise and spending time outdoors. Remember that we are hardwired to interact with the natural world, be that water, plants, or fresh air. So, the fifth principle of integrative nursing is that it's informed by evidence, uses conventional and integrative approaches. And this last piece is so important, employing the least intensive intervention possible, depending on the need and context. So, I encourage you to be thinking of symptom management along a continuum, an intervention continuum. And as somebody experiences, for example, nausea, there are many things that we can do before resorting to an antiemetic, which sometimes patients need. There are dietary interventions using aromatherapy, ginger, peppermint, blends. There are mind body practices such as guided imagery, relaxation, hypnosis, deep breathing that can be helpful with nausea. There's acupressure points such as pericardium 6 and acupuncture for patients that are experiencing chemotherapy. So, nausea associated with chemotherapy, for example, acupuncture can be a very helpful intervention, all the way to an antiemetic. But that concept being with an integrative nursing lens, thinking of moving from less intensive invasive to more. Same concept with a patient experiencing pain, exposing patients to nature. And in fact, the early studies done by Dr. Roger Ulrich at Texas A&M showed that patients who viewed scenes of nature perceived pain less, required less pain medication, and got out of the CCU more quickly. There's mind-body interventions, acupressure, acupuncture, yoga, energy therapies, massage, and we may need a pharmaceutical approach or even an anesthetic block, an intervention continuum. And you can extend this principle to applying integrative therapies more broadly to symptom management, whether that's anxiety, mood disorders, GI disturbance, fatigue, sleep, or grief. So that's that concept of that fifth principle of integrative nursing. This also can be deployed in a different way. And so we actually are really excited about creating integrative care pathways or integrative nursing protocols. And my colleague, Dr. Megan Voss, this is an example of an integrative care pathway for mental health that she's been working on. And this is a generic version, but much more specific if somebody's experiencing anxiety, depression, or a mood disorder. Level 1 are lifestyle approaches. Exercise, nutrition, light therapy, sleep hygiene, mind-body therapies, and psychotherapy. That might be a first level of intervention. Second level may be adding supplements, and depending on the symptom or the condition, different supplements that one would choose. And then a third level would be adding referrals. And so within the whole field of integrative mental health, it may be appropriate to be making referrals to functional nutrition or medicine, acupuncture, sleep medicine, substance abuse, or chronic pain. And in fact, a level 4 may be adding pharmacotherapeutics that we know for some patients are essential and life-saving. So an integrative mental health approach, illustrative of many types of clinicians, including APRNs. So I hope that you can see that integrative nursing provides a toolbox of approaches for nursing assessments, care planning, interventions, which nurses can leverage to individualize care. And then the last principle is that it focuses on the health and well-being of caregivers. And honestly, until fairly recently, self-care has been largely ignored within the health professions, and sometimes actually even ridiculed to the point that people would not admit that they were struggling because needing help or getting help was perceived as a sign of weakness. And we know that burnout has a deep impact not only on patients, but also on caregivers, and has huge financial implications for the people individually, but the industry as a whole. So I'm seeing more and more organizations saying that what we really need to do is to address both system issues that exacerbate stress and burnout, and we need to support personal well-being and create a culture of well-being where we support people in developing personal plans. And that requires investment in staff and leadership, as well as making system improvements. Well, I do want to share very briefly a case study of one of your colleague institutions, the University of California, Irvine Health, that I had the pleasure of working with for almost a couple of years. And I'm going to go through these slides quickly because I want you to get the gestalt of what a system-wide approach looked like, not necessarily the very specific detail. Pat Patton, who was the chief nurse at the time, and I believe is on the call today, now is the chief nurse of the system within UCSF. I had been working with Pat and the team for a number of months when all of a sudden the pandemic hit. I was literally on my way to the airport to fly out to Irvine, and I got a call saying, "Don't come." And a short time after that, that's a picture of UC Irvine with the tents that were set up in the parking lot to care for COVID patients. And at the time, I thought, well, this will be put on pause for sure, implementation of integrative nursing. And I was so impressed, with the boldness and clarity that Pat Patton had. He said, if integrative nursing is important, why would we wait? And so we actually went through, a systematic implementation of integrative nursing largely during the pandemic. And so these are not all linear steps, but they're the kinds of things we did. We first of all, a core team was convened that included a lot of different people. It included Pat, but clinical directors, staff development, people from patient experience, staff nurses whose voice was so critical, people from the School of Nursing, and I was part of that core team. There was a lot of focus on how is integrative nursing going to be tied to our strategic vision and our mission of discover, teach, and heal. Is integrative nursing going to help us improve health, increase value, and contribute to transforming ourselves? Integrative nursing became part of the professional practice model. So in nursing, we have professional practice models that guide our practice. Relationship-based care had been core to the professional practice model. Integrative nursing was added. And then integrative nursing became part of the strategic priorities of the institution, of the Department of Nursing. And so whether we're talking about informatics or policy, education, research, QI, collecting metrics, measurement, and reporting, integrative nursing became embedded as a strategic priority. Fairly early into the pandemic, Pat made the transition from Irvine to UCSF, and another nurse leader stepped in who really seamlessly carried on this work. Integrative nursing became embedded in the governance structure, and particularly within nursing practice. So there's nursing practice councils that sort of cross the clinical enterprise. There's division councils and there's unit councils. And the unit councils did some of that work that I described to you of really saying, what do the principles look like on this particular patient unit? So they developed a policy of integrative nursing, and then they developed practice guidelines on all the kinds of interventions that nurses would commonly do. They invested in education. And so, well, some people, some leaders within the system got deeper knowledge on integrative nursing. The intent had been that myself and others from University of Minnesota were going to come out to Irvine and we were going to do in-person education. The pandemic hit and it was like, we have to make up something new. And so we developed really just-in-time education, 5 one-hour education modules that we both presented live and were available as computer-based training that focused on integrative nursing principles, aromatherapy, acupressure, mind-body skills, and clinical massage. And I have to say that one of the joys I had working with UC Irvine was seeing how enthusiastic the nurses became. Different units all decided to track their completion of integrative nursing modules in different ways. This unit had a tree, each nurse had a branch, they put leaves on the branches, they completed the modules. This was in a very public area, so it encouraged a lot of engagement with patients and families, like, what is this about? Why are you getting educated on this? This was from the perinatal area and how they were tracking integrative nursing completion. This was from the neuropsych area. They had the metaphor of a garden and completing the petals on a flower. One of my favorite came from the post-anesthesia care units. Talk about practical. This was a flip chart on an IV pole, and people put stickers as they completed various modules. And then they began to adopt self-care practices on units: 5 deep breaths to start a shift, a quiet time inserted, and they began collecting data. This is just a snapshot of the kind of data that they were reporting back in the system, the percent of nurses that had completed integrative nursing modules. And they began looking at how does integrative nursing impact sleep, anxiety, and nausea, 30-day readmission, opioid charges per patient. And there's many different cuts of this data depending on the patient population that you're looking at, but just wanted to give you a quick sense of metrics. And what we did at UC Irvine it was go through a very structured implementation process. Cohorts of units came up at a time. We went through a 4, 6, or 8-week schedule, depending on the unit. And within those cohorts, there would be weekly meetings with the unit manager, the division educator, nurse champions. There would be huddles. And so the integrative nursing, the primary champions at Irvine would actually go, and they would actually have huddles on various units, and do what they called engagement rounding, and just be available to answer questions that staff had. Start out issues like even the simple yet complex thing of, if we're going to use essential oils to improve our symptom management, where do we store those? And you can see that even in the first phases, integrative nursing was adopted on 30 units and within 3 specialty teams, and then subsequently, the additional units. And so there were, within Epic, tools developed to assess symptoms pre and post intervention. There were drop-down menus that were created so that people could document the specific essential oil, for example, that was used. And so this kind of illustrates, how that might look. And lots of metrics were collected. The dashboards were created that looked at the volume of integrative nursing interventions per unit. And the detail actually could even go down to the level of the nurse. And so they could really see, who were the champions and who was most engaged. They created dashboards that, again, snapshots in time that would look at how have integrative nursing interventions impacted the patient's perception of relaxation, anxiety, nausea, and pain. And then another form of a dashboard was comparing people who received integrative nursing interventions with those who didn't. This dashboard is really skewed because the length of stay is so different for patients who received integrative nursing interventions, but they were sicker and potentially, and so that they were more in need of integrative nursing interventions. But then they are starting to look at really interesting data like 30-day readmission rate, opioid charges, anti-anxiety and anti-emetic charges. So it just gives you a sense of metrics. And beyond metrics, also a big focus on capturing stories. And I sometimes think the patient stories are most compelling. And this is a patient story of, I came in for an exercise stress test. I was very nervous. My blood pressure was high. There's a possibility they couldn't even do the test. The nurse was amazing. She sat down, talked with me, offered aromatherapy to help me calm down. And the intervention helped me reduce the blood pressure, so I was able to complete the test. Actually, in some of the diagnostic areas in the outpatient setting where they would actually use music and dim the lights and use aromatherapy, they were measuring the interesting metric of room turnover. So if a patient comes in is very anxious and there's delays in being able to do diagnostic testing, that can really throw off room utilization. And so it was powerful to collect testimonials, not only from patients, but also from nurses. And integrative nursing is becoming part of sustaining into 21, 22, 23, again, being embedded within the work, the operations of the Department of Nursing. So I want to just step back and reflect on why integrative nursing. And I hope that it's apparent that it's a core strategy for advancing caring and healing relationships. It's also a core strategy for achieving both clinical as well as business outcomes. And I truly believe it's an opportunity to revitalize nursing practice. So, in so many of our integrative health and medicine centers across the country, there's a lot of focus in creating clinics like the amazing Osher clinic that you have, where you care for patients both for health and well-being as well as for complex illness and chronic disease. And lots of our integrative health and medicine centers have a focus on that, or have a focus on what kind of providers do we bring into the system that provide unique services such as acupuncture. I think a real missing piece has been, how do we embed skills and capacity in existing providers so that they can practice from an integrative nursing perspective? And honestly, I think it's one of the most sustainable as well as impactful strategies. So, what are UCF's priorities? If you're like any other hospital around the country, around the world, my guess is your priorities are quality of care, patient experience, satisfaction, staff engagement, cost to care, market share, financial margin. Isn't that what's on all of our minds? Or you might say what's important is the quadruple aim. Again, looking at patient experience, population health, reducing costs, and care team well-being. Or you might say, we look at things through the lens of Joint Commission. Joint Commission now has a standard where they require non-pharmacologic approaches for pain. So integrative nursing, I hope it is apparent, is a strategy for achieving, all of those objectives. Looking through the research lens, the National Institute of Nursing research, what they have identified as priorities are things like health equity, social determinants of health, population and community health, prevention and health promotion, and systems and models of care. So again, integrative nursing can be a focus of research that touches each one of these priority areas. So in one of my last two slides, I want to just, summarize what I hope has become apparent to you, and that is that bringing integrative nursing to life requires an investment in strategies. And my first bullet is, you need to do more than talk about it or declare that it's the care delivery or professional practice model. And I have to say, and it's unfortunately sometimes a cynical approach, where I've seen organizations say, we're adopting relationship-based care or caring science or integrative nursing, and it's nothing but words on paper. Really important decisions need to be made. What do we want the patient experience to be? What expectations do we have of every nurse or of every clinician? And how will integrative nursing be the same in every unit? And what will be different based on the patient population? We need to invest in education and professional development and incorporate that into clinician and leadership role expectations. We don't say it's discretionary whether you know how to safely change a PICC line. We would never sort of say, well, if you're into it, like, learn about the safety of doing it. It becomes part of the culture of care. And that's what I aspire for integrative nursing to be. Lots of resources. You'll get a copy of these slides and you can look at those. I want to thank you for joining us today, and I'm open to any questions you might have.
Thank you so much, Dr. Kreitzer. I'm always inspired by your presentations and always made hopeful by them. So it's a nice combination of, there's a lot of work to do, but there are ways that we can actually do it. So thank you for all the practical suggestions. While people are formulating their questions, I just want to note, we do have Pat Patton on the call, and I have been in the early phases of discussion with both of these great folks to talk about integrative nursing and how we can advance integrative nursing at UCSF through the Osher Center. We have, for example, as many of you know, a clinical fellowship through the Osher Collaborative, but participation is limited to physicians. So one example of one of the more immediate ways that we can make some change is to recognize the value of providing this type of advanced training for everyone. And what I really also like about what you've been talking about is addressing the full spectrum of nursing activities. So really intervening at all different levels. So let me invite folks, if anyone would like to ask a question in person, I invite you to come on to video. And if not, or while that's happening, I will also ask some questions. Yes, Pat, please.
Good morning, Mary Jo. It's so great to see you again, at least via Zoom. I apologize for the background noise. I'm on a plane and I'm going to have to shut down here in about 5 minutes because I'm going to close the door. But I wanted to join this grand round because it was so important to me. And Mary Jo, as you said, this is a labor of love and a labor of dedication. And I have to share a personal story, Mary Jo, and I don't know if you've heard this or not. I was admitted about 4 or 5 months ago. I was at UCSF. It was during nurses week. I got severe dehydration. The physician wanted to admit me. I didn't want to be admitted. He insisted. And I said, the only way I'll be admitted is to go to UCI because I was still living in Orange County. And so they transferred me down to UCI. I got admitted to the unit that they have developed integrated the first thing they did was walk clean. They gave aromatherapy, not only set the tone for the whole admission, that made me feel not only comfortable, but in a healing process already. And I about started to cry because of the work that we had started together that came to really fruition, that I was just like, this is what came to the nursing staff while I was admitted there. It was just amazing. So I just can't thank you enough for helping us get that started and carrying on that work after I left UCSF. And I hope to do the same work with Shelley as we continue to work here at UCSF. So thank you, Mary Jo. And this really is a new model of nursing that we have to take seriously. And I know the difference personally of what it can do for our patients' lives.
Well,
Thank
Pat,
you.
wishing you safe travels. Thank you so much for those.
Thank you so much. Thank you so much, Pat. Now, because the audio wasn't quite good, I just want to briefly relate what Pat was saying, because I happened to, he has shared this experience with me, which was that he was unexpectedly hospitalized actually at UCI, and ended up being the direct beneficiary of the wonderful work that that Mary Jo and the UCI team and Pat himself had done, and experienced firsthand the impact of integrative nursing. So it came full circle, and it's a very powerful experience. So thanks so much, Pat, for sharing that, and very excited to be have our center be working with you. Another question has to do with the actual form of the training at UCI, and is it mostly online, self-directed now? And if you could just describe a little bit more about the modules, Dr. Kreitzer.
Sure. And so the education has continued to evolve, and it's, I would say, a layered approach. So concepts of integrative nursing are now integrated into new employee, new nurse orientation of every nurse. At some point, they're asked to complete integrative nursing modules. And in addition to those modules, then on the patient care unit, they've developed skill-based evaluation and sort of check off. So they're really integrating it into their whole competency structure. Integrative nursing, during, in nursing, we often have skill competency days once a year. It has become part of that. I think it's become a strong part of continuing education. So if there's a new topic that's being added for, education, professional development, the integrative nursing lens or concept is integrated into that. So I think it's become, Shelley, so much more than just completion of the 5 modules, but a very high percent of the nursing staff, and I think it's well above 90%, completed that baseline education. Then in addition to that, when I said some people completed more education, on Coursera, and Coursera is education for the world. There are Coursera courses in many, many topics, including healthcare topics. We have developed a specialization on integrative nursing where there's a much more in-depth course, like on aromatherapy, instead of, an hour-long topic like we did at UCI that was very related to their policy, their practice guidelines, their formulary of essential oils. People who want more in-depth education can complete, a module that's, I don't know, probably 30 hours long. And that Coursera education is almost free. It's so cheap.
Mm-hmm. We have some interprofessional courses on Coursera. And for folks that know, this is one of these MOOC platforms, massive open, what does the C stand for? Course. Massive open online course.
Yeah.
Thank you. Another question has to do with something. So we've known for a long time that nursing as a field is particularly aligned with principles of integrative health, in some ways independent of integrative health in terms of values, but there's such a natural affinity. A question has to do with something that I think is often not named in these discussions, and that is the medical hierarchy. And the question has to do with, do you have suggestions or strategies for people wanting to include integrative nursing, but understanding that we are still in academic health centers like our own, very much in a medical hierarchy with nurses not at the top of the hierarchy?
Yeah, no, it's a really good question, Shelley. And honestly, everything that I've talked about in terms of integrative nursing falls within the legally defined scope of nursing practice, including using those interventions, those integrative therapies and healing practices. And so it actually is not a situation where permission of physicians is required any more than for other nursing interventions. Having said that, to advance this from an interdisciplinary perspective, of course, it's very important when, working specifically on a heart unit with the cardiovascular surgeons and cardiologists to be saying, as part of our integrative nursing practice, we will be, doing and, using, these things, and this is why. And so having that conversation is important. But in most places that I've been doing this work, it hasn't bumped up against the hierarchy in terms of like, we need to get permission for. Now, I will say, Shelley, there are a number of institutions where I think nurses are really disheartened, and because they can't practice the way they want to practice, and maybe they don't even have support within nursing for bringing in things such as aromatherapy or mind-body practices. And what I often say to people like that is, after you hear a talk like this, the next patient you see, lay hands on, you can be practicing integrative nursing, because integrative nursing is so much more than just the therapies. And so, I think, as you said, the importance of instilling hope in people. I really want to help nurses and others gain self-efficacy in terms of tools, but also really a belief in what they can own in terms of their practice autonomously.
Mm-hmm. You've mentioned this as one of the pillars, but the idea of the well-being of practitioners, I know that we agree includes a lifelong learning and being able to embrace what is meaningful to you in your practice and advance your skills. So I think there's an educational healing aspect there as well. We have come very quickly to the end of our time. let me see if I can ask one more question here, with the understanding that people will be trying to get to a clinic within the next few minutes. But let's see, Carter, are you available to ask this question yourself in a succinct way?
Yeah, I am. Can you hear me?
Thank you, Dr. Laveris.
Hi, good morning. Hi, Mary Jo. It's so great to hear you and be inspired by you this morning. I love how in like a quick minute, I feel like you fill my entire mind with everything I need to know. One thing that really has struck me about your work over time and in this talk is your awareness of the financial metrics and keeping in mind how important it is to think about those and speak to those where possible in order to have sustainability and sort of economic buy-in from institutions. I'm wondering, you mentioned multiple frames through which to view this, and I'm just curious your experience or thoughts on currently which frameworks, whether it's the Joint Commission or patient-centered outcomes, that you think is sort of most powerful in this moment, especially for people proposing sort of new integrative medical or nursing initiatives, where we might best focus some of our data capturing in order to help in this area.
Well, Carter, it's great to hear your voice. And I know Carter back almost, I would say, decades ago when she was a medical student at the University of Minnesota. And I would say, Carter, that, you know, in terms of financial metrics, I think there's two that are really important to keep, you know, one's eye on. Certainly, you know, anything that enhances patient satisfaction, patient experience, that actually can have an impact on market share, and that directly affects the bottom line. So I think, you know, that is certainly one to look at. I think impressive data is coming out about the reduction in the use of pharmaceuticals when we do better symptom management with non-pharm approaches. And everybody's concerned these days about opioid use. And so if we can be looking particularly with pain, you know, at non-pharm approaches, I think that's a metric that we should be, you know, highlighting. And then the third one I would say is the whole well-being of the healthcare workforce. I mean, I could have given like hours of talk on the impact of stress and burnout. And, you know, what's really crushing is the impact it can have on patient errors, which is costly. Turnover and exit from the profession. And there's a huge societal loss when we have nurses and physicians and others leaving the profession because they're so stressed and burnout. And, you know, the data right now is so astounding. I mean, up to, you know, over 50% of some physician specialties and nurses, you know, have an intention of leaving the profession. You know, that's crushing. And so those are things that I think we really need to be keeping our eye on.
Thank you. Thanks for the question, Carter. Thanks for the answer, Mary Jo. And I want those who have not had to leave for clinic to join me in thanking you so much for being with us today. Always a tremendous pleasure, and we're very grateful to you.